Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishinabeg, ogo ka nagadawambandajig, iyo aki ekoweshkad, akonongom egawikad ki migiwewaj. Nimanajiananig kakina anishinabeg undaje kaye ogog kakina eneagizijig, enekukamegak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Well, good morning, good afternoon, good evening, welcome to September's edition of Family Medicine Grand Rounds. My name's Doug Archibald. I'm the Director of Research and Innovation for the Department of Family Medicine, University of Ottawa, and I'll be this morning's moderator. It's with great pleasure that I introduce three speakers for two presentations this morning. First of which is Dr. Julian Abel, who's coming to us from the UK this morning. Throughout Dr. Julian Abel's career as a palliative care physician, he's become increasingly involved in finding ways of building compassionate communities to support people at the end of life. He's currently the Director of Compassionate Communities in the UK. Since 2016, he's worked with From Medical Practice in Somerset, UK, to develop a new model of primary care combined with compassionate communities, one of the most effective therapeutic tools they have in improving length and life of well-being. The health outcomes of this model have been dramatic, with this being the first intervention that has been effective in reducing population emergency emissions. He co-authored the book About From, called The Compassionate Project. Dr. Abel, Professor Alan Kelleher, and Dr. Catherine Millington Sanders formed the Compassionate Communities UK, which aims to develop the broader rollout of compassionate communities in both primary care and end-of-life care. Projects are underway in multiple areas in the UK and several international cities. Professor Kelleher and Abel are joint editors in the forthcoming First Oxford Textbook of Public Health Palliative Care. He's an author, an international keynote speaker, and runs the podcast Survival of the Kindest. So without further ado, Julian, I pass the torch to you.
Thank you very much for that introduction, and thank you also for the opportunity to talk to you all. When I was requested to give this talk, and we had a conversation about what it might have in it, I said, well, does it matter if I'm controversial? And the answer came back as no. And in fact, the more controversial, the better. So I'm going to be very controversial, and it's not in any way to insult anyone, but it's more a way of hopefully stimulating some different thinking. So I'm going to start with this slide. To me, this is the most important slide in medicine that I've seen. Slide showing the impact of social relationships on mortality over a 7.5-year period. It's a study done by Julian Lundstedt, looking at 148 different research projects with over 300,000 people. And as you can see, that social relationships are more effective at keeping us alive over that short period of time than giving up smoking, drinking, diet, exercise, and anything else you care to mention. And in particular, I've highlighted the drug treatment of hypertension because we put so much effort into treating hypertension, but if we really wanted to use the best therapeutic tool we've got, then we should be using social relationships, which outweighs drug treatment of hypertension on death by a factor of 4. Now, I thought it'd be a good idea if we just had a listen to how carefully this study was conducted. And if you can't hear this, can you please shout out and let me know?
Yeah, so we wanted to make sure that we were looking at social relationships quite broadly, because part of the question was that in the literature, social relationships have been measured in a variety of ways. And so I wondered whether part of the lack of recognition might be due to this lack of precision that's more typical in biomedicine, to see whether there was perhaps one measurement type that might be much more predictive of mortality risk than another. And so we searched for basically any epidemiological study that had measured some aspect of social relationships, and then was a prospective study, so followed people over time, and had to measure some type of mortality. However, one of the things that we did limit was that it needed to be disease-related mortality or all-cause mortality. So all-cause mortality meaning they just simply reported whether people were dead or alive, but didn't necessarily report the cause of death. But if there was a cause of death reported, we limited it to disease-related mortality and didn't include mortality related to suicide, violence, or accidents. And it's not because we didn't think that these were important, but like I mentioned, at the time, it really wasn't acknowledged as being relevant to physical health. And so I was afraid that if we included suicide in there, that perhaps the findings might be discounted as being entirely driven by suicide.
I think that the point about the way that Julian conducted that study was it was incredibly careful and painstaking, and the results are really clear. And as you can hear, that excluding things like suicide, trying to control it as much as possible is probably an underestimation. And then when you look at the morbidity as well as the mortality that comes from social isolation, you can see that it's incredible. Loneliness among heart failure patients was associated with a nearly, just have to move that, 4 times increased risk of death, 68% increased risk of hospitalization, and a 57% increased risk of emergency departments. There's something really profound going on here. And this is more than just a psychological impact. So the way that you can look at this is to think about it in terms of 3 levels. I mentioned 3 sisters because I recently read a book by Robin Wall Kimmerer about, she's a biologist, and her name's gone out of my head. I'm searching around for the book at the moment. But 3 Sisters Planting is a way of planting together in which each of the things that you plant feeds the other. And so it's about interrelationships rather than thinking about silos. So organization of our nervous system, human social genomics, and relationships. And when we think about how our nervous system evolved, actually the way it's organized is in layers, the heart of it, lying at the heart of our brain, is our reptilian brain. That's largely to do with the housekeeping of the body, such as heart rate, breathing, diet, all that kind of stuff, digestion of food, etc., etc. Surrounding the reptilian brain, we have the limbic system, which is the mammalian brain that carries emotions and memory and has a variety of other functions, including the warning system of danger in our amygdala, which is really important. And then we have the neo-mammalian brain, which is in particular the prefrontal cortex, which is the place where all the connections are made. On the one side, we have imagination, intuition, and on the other side, we have reasoning and logic. And for us to be fully functioning human beings, the whole thing has to work together. How does this work in terms of what's happening in the body? Well, one of the ways that it works is through what Stephen Porges calls the Polyvagal Theory, which is looking at the anatomical and neurophysiological effects of the vagus nerve and looking at all of the interconnectedness. The point about this is that there is a way in which the messages of our nervous system and what's happening to us at an emotional level, including social relationships, which are absolutely key, is fed down into our body. We have, if we think about our evolution, then we can think that we evolved in, small groups of anything between 25 and 150 people, and we were like that for about 1.5 million years as humanoids and hominids. And as survival of the fittest is some kind of dystopian nightmare of British imperialism. It's a phrase invented by Herbert Spencer. It wasn't invented by Darwin. It was the beginning of social Darwinism with all the racist overtones that go with that. And actually, survival of the kindest is a much better expression of how we evolved. And there's plenty of a wide variety of different evidence to show that this is the case. And emotional regulation, emotional expression is really important in the context of pro-social behaviors. And that includes all the body language, et cetera, et cetera. So that looks really good, but how does that work down to a biochemical and genomic level? And I strongly recommend listening to Steve Cole on Survival of the Kindest podcast, because he describes in detail about how loneliness has an impact at a genomic level that results in chronic inflammation, and that this chronic inflammation is closely connected with so many of the diseases that we now suffer from, including heart disease, cancers, chronic lung disease, and autoimmune disease. And interestingly, as well, he showed very clearly that in the context of loneliness and the genomic expression that comes from it, we have decreased viral resistance. And when you think about that in terms of, from an evolutionary perspective, that our bodies are geared for disasters. We have traumatic disasters, like we're attacked by a saber-toothed tiger, or in fact, if we're separated from our community, that is a dramatic event, because our food security, our warmth, our ability to bring up children is affected, and our body prioritizes dealing with getting out of that situation and dealing with major traumatic injury rather than viral infections. And it's very interesting to note in the context of the pandemic, obviously. So the bit about relationships, I've got a clip from Robert Waldinger, who gave a TED talk about this matter, and I thoroughly recommend it. And I've got some resources at the end that you'll be able to look all this stuff up. The Harvard and Glueck study of adult development has been going on since 1938, and tracked the lives of men, and over the last 20 years, women, from Harvard. And they started with Harvard because I think they thought at the time that if you go to Harvard, everyone's going to be happy and smiling. And they discovered that wasn't the case. And they thought they'd better have a look at the poor area of Boston as well. Anyway, so let's hear what Robert Waldinger has to say about this.
Time. So what have we learned? What are the lessons that come from the tens of thousands of pages of information that we've generated on these lives? Well, the lessons aren't about wealth or fame or working harder and harder. The clearest message that we get from this 75-year study is this: good relationships keep us happier and healthier, period. We've learned 3 big lessons about relationships. The first is that social connections are really good for us, and that loneliness kills. It turns out that people who are more socially connected to family, to friends, to community, are happier, they're physically healthier, and they live longer than people who are less well connected. And the experience of loneliness turns out to be toxic. People who are more isolated than they want to be from others find that they are less happy, their health declines earlier in midlife, their brain functioning declines sooner, and they live shorter lives than people who are not lonely. And the sad fact is that at any given time, more than 1 in 5 Americans will report that they're lonely. And we know that you can be lonely in a crowd and you can be lonely in a marriage. So the second big lesson that we learned is that it's not just the number of friends you have, and it's not whether or not you're in a committed relationship, but it's the quality of your close relationships that matters. It turns out that living in the midst of conflict is really bad for our health. High conflict marriages, for example, without much affection, turn out to be very bad for our health, perhaps worse than getting divorced. And living in the midst of good, warm relationships is protective.
The point about social relationships is that they are a very powerful therapeutic tool. And what happens if we put them into practice? Well, this is what happens. These are the emergency admissions in Frome, over a town of 28,000 people over a 4-year period as we instituted this project. And the graph, the blue graph on the right, is emergency admissions in Somerset over the same period of time. The admissions in Frome went down by 15%. The emissions in Somerset, a county of 500,000 people, went up by 30%. This is this thing here is a medical disaster, and it's plaguing Western health systems. And there are no interventions which have reduced population emergency admissions. I want to just make the point that there's a distinction between population emergency admission reduction and cohort reduction, where you take a selected group of people and you give them intense intervention, and you can make changes to their hospital usage, but at the same time, population emergency admissions continues to grow. So the point about this is that when you look at it from the perspective of evolution, it makes sense that social relationships have such a profound effect on health. So what the point about what we did in Froome is that it's a whole population intervention. It takes place both in primary care and in the community. And to get systems reliability, we use IHI quality improvement methodology to institute the change. And you can think of this as the same as hypertension. So what we do with hypertension is we screen people to see whether they get high blood pressure. We do an investigation to see what the cause of their high blood pressure is, and then we manage the high blood pressure with an ongoing check. Well, why don't we do the same with social relationships? Why don't we assess in every patient something that is most fundamental to their health, which is their social relationships? And why don't we build communities, compassionate communities, and link those people with those compassionate communities? And why don't we check to make sure that what we've done is actually improving their health? And I can tell you that when you do this, you see transformation in people's lives that you would never see with medication. It is absolutely a profound event. In the context of the 3 levels of action for social relationships, you've got the first thing you can do is you can link people with the community resources, and every community has got hundreds of groups going on. And amongst the participants here is Mary Lou Kelly, who and Nick as well, who are deeply involved in Compassionate Ottawa. And they will already be gathering a lot of this information together. There's some people will benefit from one-to-one work where they don't have the emotional resources to link with their community or even know what their problem is. So that the role of the health connector is for that one-to-one work and figure out with that person what needs to happen. And then there is the discover, explore, and enhance people's personal network, something that we all have. In the context of what you do in primary care, there are 4 key steps. I've identified those in need of support, and that's assessment of every person who comes through the practice, assessment of their social relationships, then doing the patient-centered goal planning. What is it they want? What is it that matters most to them in their lives? And then the next bit is about making sure that the complex ones are discussed at your multidisciplinary team meetings. And then, as we were saying, enhancement of the naturally occurring networks and linkage to community resource. And I think I'm just going to finish with a couple of slides now. This is Anne Robinson, who's a Guardian journalist and also a GP, and she describes what she was writing an article about Froome, and she describes what she saw in her surgery on the morning that she wrote the article. In my GP surgery this morning, I had nothing to offer a significant proportion of the people I saw. People with lifelong depression, low self-esteem, agoraphobia, and anxiety have become socially isolated. An elderly man and a young mother, both feeling the effects of loneliness and lack of social support. A man in his 60s who has recovered from a heart attack but is finding it hard to motivate himself to overhaul his lifestyle by stopping smoking and starting to exercise and eat healthily. A young man who has back pain for which no specific diagnosis or treatment can be found despite intensive investigations. An elderly, frail lady who is so scared of falling that she's become a prisoner in her own home. And I am sure that many of you will recognize in your morning surgeries people like this. So the way that we can think about this is that that medicine is actually an illness service, not a wellness service. Absence of disease, absence of symptoms, whether these are physical, social, psychological, or spiritual, do not give health and well-being. Health and well-being is to be found in the people we know and love, in the places we know and love. And in particular, when you're thinking about people with chronic disease, their social function is diminished as a consequence of the chronic disease. And they have the double whammy of having the disease and having the pro-inflammatory reaction to loneliness to make their disease worse. And a way of resolving that problem is to think about group consultations and group programs where people can find out the solutions to their health themselves. So if we are to ask the question, has medicine lost its way? I would argue yes, and badly. We are badly out of kilter. Medicine is about human beings. It is about love, laughter, and friendship, human connectedness, and meaning and value in life. So I've got a list of resources, which I'll happily share with you. As I say, I'd strongly recommend listening to Steve Cole on Survival of the Kindest podcast, because all the information that we need to know that social relationships have a profound impact on how we function as human beings is already there. The science is done. We don't need more. We just need to look and see what's there. Thank you.
Dr. Abel, thank you very much for that message. I open the floor now for questions. So either put your hand up and ask your question, or pose it in the chat. And I can already see that there's questions coming in. So the first one is from Simone DeRouge. GPs can recognize this in some of their patients, but it's likely not evident for all. Is there active screening a preferred tool?
Maybe
I think.
Maybe go ahead, Simone. Yeah.
Can I preface my question by saying, excellent talk. I completely agree with you that a life is not worth living if you're medically well, if you're not socially connected and emotionally well. So really amazing work that you're doing. And I might say that maybe it's not that medicine has lost its way, but maybe it hasn't connected with the other sectors, other resources that can support medicine in achieving its goals. And I work in a bit in this area, and I'm delighted that you're here to join us today.
So thank you for that. And so I think that there's the business about assessing everyone's social relationships. I think it's helpful to think about it in the context of blood pressure, because we measure everyone's blood pressure. Now, it doesn't mean that the GP has to measure the blood pressure every time they see a patient, but that information needs to be on the clinical record. And and we can think that actually in the context of compassionate communities, it's a whole practice intervention. It starts when the patient rings in or walks through the door and talks to the receptionist, and then every single member of the team needs to be tuning into this because it's of such fundamental importance. And the key is, so screening tools, often they are crass and insensitive. And you have to figure out in each of your own practices how to do this in a sensitive and meaningful way. I don't think there is one single answer to this. And in particular, one of the, I seem to be, I don't know why, but racism and lack of diversity is kind of at the front of my head these days. And that screening tools often exacerbate racism and lack of diversity. And I would suggest having a listen to Nahid Dosani on Survival of the Kindest. He's a palliative care physician who works with the homeless, and he is so eloquent about this subject. So I think it's about the individual and working out how to communicate one person to another.
Thank you. Dr. Liddy, Claire.
Oh, hi. So I'm Claire Liddy. I'm the chair of the department. Nice to meet you, Dr. Abel. I echo what Simone said. Fantastic talk. As a family doctor who's had, patients come in and you feel like you can't do anything, I can certainly appreciate that. So my question is a really practical one. It kind of follows up from Simone in a sense, but so, we would like to do this in, this region, Ottawa and Greater Champlain. And we have a lot of practices, teaching practices associated with the Department of Family Medicine. So I would just like what do I do next? Clearly, I'm going to talk to Nick Busing, but you know, I'm looking for, it's exactly as you said, like, I don't really want the list of the 15 screening tools that then we can distribute to the practices, or like, it's clear, I'm just, I'm really excited, and I see the value, and I would love to be able to implement this. So a couple of steps.
Let's arrange a conversation, but just
Yep.
get in contact. And I think that's the simplest way. It's a complex intervention.
Yep.
It's about mapping what you already have in your community. It's about rethinking about how your family medicine works, and it's about joining the two together. There's a good deal of complexity. It needs investment, and it needs, most of all, the hearts and minds of the people involved. We started Compassionate Communities UK in part to support people who are interested in doing this kind of work. And you already have a lot of interest in this area, you know, like you're saying, with Nick and with Mary Lou, who's got tremendous experience in this area, and particularly working with First Nations communities. So that's part of the wealth of what you already have. And the question is, well, what else is needed to be able to make this happen?
Right. Fantastic. Yeah. When I look around the room of everybody who's here today, I feel like, okay, we've got all the people with the passion and almost all the ingredients there. So I would like to, I guess, throw the challenge out and invite folks, or maybe you can invite me to what you're already doing, because I'm extremely aware that there's a lot of activity going on. But the Department of Family Medicine would like to fully support this type of approach for our community. So I'll follow up with you.
Yeah, you're welcome. Yeah.
I'm excited. Yeah. Thanks.
Thank you. Please keep your eyes on the chat. There's some great comments there, as well as the YouTube link where this presentation will be housed. A number of people have asked about some of the slides, so you definitely see the presentation in the next little while. Okay, Prisa.
Good morning. Thank you. What a wonderful way to start another season, gloomy season in Ottawa. I think, Julian, I wonder if as educators, it is also upon us to teach the next generation of physicians that it's actually in our best interest to be engaged emotionally and compassionately with our patients, because it has this positive, as you demonstrated in your first couple of slides, on our well-being, right? We know that compassionate care actually protects us from burnout. Not the way that people see it, that if they spend another 5 minutes with a patient, or if they do a house call, that they're exhausted. I find it in the past 20 years, that's what keeps me going, because of that humanity. And sadly, and particularly in the past few years, with the creation of electronic health record, just the eye contact, and it has been taken away from us when we're seeing our patients, but more importantly, the emphasis on imaging and other investigations, rather than holding our patients' hands or taking their pulse, which Gary talked about, right? We know that skin-to-skin contact really improves patients' well-being, but also our well-being, because at the end of the day, we're all human beings who need that. So I wonder if, as a group, as a department, if we were to have this as a priority, to change a little bit the shift, to teach our residents and practice it, this compassionate care, and remind people that taking their heart rate may not mean anything, but makes all of us feel so much better, including clinicians. Just a reflection.
I think that's absolutely true, and I think we can ask ourselves, is the health system that we are working in traumatizing? And I think if we If we all looked at our experience of interacting with the health system, we would find that it is traumatizing, that we're asked to do things that we know don't help, and that we witness suffering as a consequence of that. And we often feel powerless to do anything about it. And there you have the definition of trauma. And I think that when we think about, just sometimes our ability to be compassionate is impaired because of the traumatic environments in which we work, well, that plays a significant part. And compassion burnout, I don't believe exists. We get exhausted by the systems in which we work, but the compassion never goes. It's always there.
Dr. Abel, thank you so much for a wonderful presentation and great discussion, everyone. It's with great pleasure now that I introduce our next two speakers, Dr. Peter Tanuseputro and Ms. Christina Milani. Dr. Tanuseputro completed his training as a public health and preventative medicine specialist at the University of Toronto. He's currently an assistant professor in the Division of Palliative Care in the Department of Medicine, and cross-appointed to family medicine as well. He practices family medicine in the community with a focus on palliative home visits. His research focuses using or linking health administrative databases to explore healthcare and use outcomes associated with aging and end of life in Ontario. Christina completed her undergraduate training at Carleton in neuroscience and mental health and psychology. She holds a master's degree in epidemiology from Queen's, and her research interests are predominantly in the area of psychiatric and community health services research. And she is a clinical research coordinator with Peter on various projects related to health services usage, palliative care, end of life, and chronic conditions. So Christina and Peter, over to you.
Yeah, thanks, Doug. And I'm going to start, Christina, if that's okay. And no, it's wonderful, Dr. Abel, that you're able to join us. As you can tell, I have a background in public health. That's my Royal College specialty. I'm situated in the Division of Palliative Care. I'm very much passionate about the delivery of palliative care and increasing access of palliative care, particularly in community settings for individuals who are in their terminal phase of life. And when I first heard of the palliative care approach, the public health approach to palliative care, I was very curious to hear about what that is, because throughout my public health training, it just wasn't a concept that we were familiar with. And the more I read into it, and the more we read about your work and Dr. Keller here's work, the more I realized that it makes sense. And I think one of the catchphrases that we really espouse is that palliative care is everyone's business. And one of the things that we've been pushing for in Ontario and across Canada is the involvement of what we call generalists in palliative care, which includes predominantly primary care. That it's not about palliative care specialists delivering end of life and palliative care, but the involvement of primary care is very important. That's the first point I want to make. Sorry, I'll try to keep this brief. But we've been involved with the convention committees in Windsor, Essex, and now it's great that Nick and Mary Lou is on the call. Anything I can help to push it along, anything that our team can help to push along will be great. We have built prognostic sort of tools to help people open up conversations about death and dying. Some of you might have heard about our Respect tool. If you haven't, maybe Christina, you can put the URL. It's respect.projectbiglife.ca in the chat, or I can do it later. But essentially, we've had since the release, I think a couple of months ago, we've had, and Amy Shu is the primary person who created, and I see she's on the line. We've had over 800,000 hits on it. It's generated a bit of controversy, in the sense that should we empower or should we allow? I'm going to use that word loosely. Allow patients and families and caregivers to know what their prognosis are or is. And we've gotten a lot of positive feedback from patients and from families. There's also a thought that should this be done in shared care with a practitioner? But it is one of the things that we're passionate about, empowering patients and families and caregivers, the ability to have evidence or have information about what's happening to them. And our mission is to kind of increase this so that all individuals have access to quality palliative care. We also have, I'm going to stop after this. We also have a project others in the room might be interested. Colleen Weber is a research associate on our team in the division of palliative care. And we're looking at the impact. I see Ben Robert is here, the impact of social isolation before, but also during COVID in nursing homes. So in nursing homes, obviously, anytime you go into lockdown and during the pandemic, these individuals are extremely isolated, right? And without that social connection. And we're going to look at how that impacts cognition, how it impacts people's IADLs and ADLs. And in general, I think anecdotally we've heard a lot about all our dementia patients really taking a turn for the worse. But I've seen it in my primary care patients, those who have MCI, really take a turn for the worse, and we're going to put some numbers to it. And so I think that's an exciting study that we'll take on soon. Okay, all that, I know we're going to run out of time. I always do this. Christina, do you want to take it away? I think you have slides that you're going to share. And thank you, Christina, for preparing this. And she's going to do most of the talking, and I'm just going to add running commentary basically. And we can keep this informal. I know it's a big group, but normally we do this quite interactively. Are you able to share, Christina? But I'll tell you a little bit about the background to this study. And so our talk is talking about delivery of palliative and end-of-life care during the COVID pandemic, but also prior to the COVID pandemic. And this project came about by a request during the first and second wave of COVID from the Ontario Palliative Care Network and from Ministry of Health. And they asked us, can you help us identify the homes that are struggling to deliver palliative care? And right now, there's absolutely no way to do that. There's no measurement of end-of-life care and palliative care. And James Downer, who's division head of palliative care, and I, we kind of kicked the can around on this, and we came out with a proxy. We think a very good proxy of identifying who's getting quality palliative care at the end of life in nursing homes. If you can go to the next slide, Christina. So we applied for funding so we have about 4 funding sources over last year for this. The CORIG from CCFP, which sets the foundation for the quantitative analyses. We've received funding from CORIG 2. That's to look at, I guess it'll make sense once Christina presents it, but looking at prescriber characteristics, how it impacts the propensity to deliver quality palliative care. So looking at characteristics of family physicians or physicians in nursing homes and seeing how that impacts their ability to provide quality care. And we link CPSO data to ICS to do that. We have funding to replicate this from Ontario to Alberta with a qualitative portion. We have funding from CIHR or CFHI as well. And we just recently received funding from national agency that wants to remain anonymous to do this project as well. Go next slide, Christina. I think I'm going to hand it over to you. And I think we probably will have to be brief, unfortunately, Christina. Sorry, because I took up a lot of time, but go ahead, please.
Yeah, no problem. So in Ontario, the median survival after admission to long-term care is only 18 months. So that really speaks to how essential palliative care is in long-term care settings. And a central component of palliative care is the ability to manage symptoms and provide relief for those symptoms that occur at the end of life, one of which is pain predominantly. As we all know, long-term care homes have been disproportionately affected by the COVID-19 pandemic in Ontario and across Canada. And so we've started this work in kind of the pre-COVID era, but we are beginning to and want to continue expanding this work into COVID times and to see how prescribing has changed during the pandemic. So this led us to come up with several research questions, which are, can the prescribing of end-of-life symptom management medications be used as an indicator of care quality provided to long-term care residents as they approach the end of life? And so when we say end of life, we're really talking about the last 2 weeks of life, as this is when it becomes quite evident that people are approaching the end of life. And this is when the symptoms really start to manifest. What is the impact of the COVID-19 pandemic on end-of-life prescribing in long-term care? And what factors or characteristics at the level of the physician prescribers as well as administrators of medications, so nurses, long-term care residents and long-term care homes may be associated with better or worse prescribing practices. So we have quite a large team on this project, and we've worked with a lot of our clinician and palliative care, long-term care consultants on our team to come up with a list of appropriate end-of-life medications that should be prescribed at the end of life if these symptoms are present. And so the idea here is if these medications are not being prescribed, this may be an indication that the highest quality of care is not being provided to certain patients or residents.
Yeah, and Christina, and I just want to make clear, sorry, I interrupted you, but this is subcutaneous medications. So I think everyone knows, or most people here know that, when a person is dying, almost everyone loses the ability to swallow pills, but almost everyone will have some of these some of these symptom needs. And so a good practice in palliative care is to get ready and to prescribe subcutaneous medications and have them ready at bedside. In a home, for example, we order symptom relief kits that we have bedside so that when they lose the ability to swallow, we can administer these subcutaneous medications near the end of life. And it's just a proxy of, that prescriber or that provider, really thinking about palliative care and having an expertise in delivering on palliative care. Because this, I think, if you practice palliative care and this is your jam, then you should be, doing this for most patients. I just want to make that clear, Christina. Sorry, go ahead.
Thank you, Peter. All right, so now we'll move on to some of our findings that we have yielded so far from this study. So first of all, just for some background, we took all the long-term care homes in Ontario using data held at ICES. Through the Ontario Drug Benefit Database, we were able to identify these medications, how often they are prescribed across long-term care homes. And based on 1+ prescription for a resident in a given home in the last 2 weeks of life, we've divvied up these homes into 5 quintiles, with quintile 1 representing the homes that have the lowest prescribing rates, and quintile 5 containing the homes that have the highest prescribing rates. So in this first table here, we recognize that not everyone in long-term care will end up dying in long-term care. There are often transfers and people end up dying in hospital out of long-term care. So we wanted to see in our study cohort what this looked like. So in the second 2 rows here, we have the number of residents who died in long-term care stratified by prescribing quintile, as well as the number of residents that transferred out of long-term care in the last 2 weeks and died outside of long-term care. Peter, I don't know if you wanted to comment on anything else with this.
I think Claire put it in the chat too, Christina. It's staggering, right? Like the Q1, and these are not small. I mean, 126 homes, right, with thousands and thousands of patients. Prescribing rate 37.6%, right? 37.6% of decedents received one of these subcutaneous medications before they died. You look at Q5, it's over 80%, right? It's huge differences. And what you can tell as well in Q1, the homes that do not provide these subcutaneous medications on a regular basis, they also transfer most of their patients, more of their patients out to the ER. So it's a signal to us that perhaps, extra training and support for providers in Q1 might help, that end of life care, right? That perhaps they have not that ability to provide that quality palliative care. And we're not blaming anyone. It's just the variation. When you say greater than 2-fold increase, we're talking about thousands of deaths, right? Thousands of deaths that have no symptom relief, support at the end of life. And it's not about the numbers, it's about the quality of end of life care that these people receive. But it's just staggering, I think, the variation.
Absolutely. So this next table is a continuation of the table we just showed, but a bit more granularity here. So this divides up all the classes and individual medications that we wanted to look at, again, stratified by each prescribing quintile. So the most variation, and again, this was reflected in the any or all medications row that we saw in the last table, was the opioids. So variation Q1, 35.9% of residents received at least one opioid versus 81.2% in Q5. So again, quite staggering. And just to reiterate, this is all data pre-COVID. So to further define what we mean by pre-COVID and COVID, our pre-COVID study period spanned from January 1st, 2017 to March 17th, 2020. And our COVID period goes from March 18th, 2020, which is the day that the provincial government of Ontario declared a state of emergency due to COVID-19, to December 31st, 2020. This is just as it is right now, how far the data is up to date in the ICES databases. So I will preface this by saying that our COVID data is very preliminary. We are still working out the kinks of this, and we want to take a deeper dive into the differences between the pre-COVID and COVID periods. But what we're looking at here is the mean percent of residents from each quintile that was prescribed at least one medication, any overall those classes that we showed for the pre-COVID period versus during the COVID period. So what we can see here, again, the largest differences across the two time periods are in quintile 1, so the lowest prescribing quintile, and quintile 5, the highest. And interestingly, from pre-COVID to COVID, the lowest quintile prescribed even lower, or so to speak, did even worse during the COVID period. And the highest prescribing quintile prescribed even at an even higher rate, or to more residents during the COVID period than they did pre-COVID. So the worse got worse and the better got better, essentially. And Q2 through Q4, there were differences as well, but again, not as staggering as the quintiles on the extremes. We also, for pre-COVID versus COVID comparisons, we wanted to stratify by LINS, just because obviously this is very relevant to Ontario public health, just to see if there were any discrepancies there. And we got a bit more granular with this data. So we do have information for the proportion of residents who received any medication, as well as specific medication classes. So I'll highlight a few notable findings here. Toronto Central overall had the lowest prescribing rates for any medication, as well as opioids pre and during COVID. And the best LINs were North Simcoe, Muskoka, and Northeast for any medications and opioids pre and during COVID.
Again, huge variations, right? And Christina, I'm sorry to do this, but we probably should wrap up in a couple of minutes. But huge variations, right, across regions. These variations should not exist, basically, right? Yeah.
All right. So we did have, again, benzodiazepines and antipsychotics we looked at as well, which was a bit more heterogeneous than anti and opioids. So again, with this, as we talked about, we want to look at characteristics at the different levels that are involved in this research question. So to date, we've looked at several home characteristics and a slew of resident characteristics to descriptively look at the distributions and their potential associations with end-of-life prescribing. So I'll jump to the notable findings that we've seen so far. So for home characteristics, we looked at rurality and size, which was defined by the number of ministry designated beds. And we noticed large variation with both of these variables. So homes in the lowest prescribing quintile tended to be in more urban geographic settings, and they tended to be larger in terms of bed size as well compared to all other quintiles, which was quite interesting to us. As well, at the resident level, it was interesting that there was not a lot of variation among the resident characteristics that we looked at, which really speaks to the variation is coming from the home and potentially the prescribers, the physicians, which we have not looked at yet. That could be a study in and of itself. But one thing that we did want to point out at the resident level was the language spoken at home. So in the lowest quintile of homes that prescribe, they had a much larger proportion of residents who are allophone. So those are individuals who don't speak, their first language is not English, French, or an Indigenous language. And then in the highest prescribing quintiles, most of their residents are English speaking or Anglophones. So this might speak to some ethnic language. Of course, all of these things are interrelated, some disparities that are happening there in care. So we definitely want to elaborate on that in future work. And moving forward, we plan to further explore the impact of COVID-19 on end-of-life prescribing. We want to look at the impact of outbreak status, timing of outbreak, things like that. As mentioned, we want to take a deeper dive into all of these characteristics that are associated with prescribing, not just descriptively, but inferentially as well, running some bivariate and regression analyses to identify potential predictors of better or worse prescribing. We're also working on a qualitative complementary study to this work, because obviously we can't capture everything that's going on with this admin data. So we really want to see what's happening behind the numbers by interviewing physicians, nurses, informal caregivers in long-term care homes to better understand the enablers and barriers to prescribing, and to also understand people's attitudes towards potentially using end-of-life prescribing as an indicator of care quality. And lastly, we want to replicate this quantitative and qualitative work in Alberta with our partners at Alberta Health Services and University of Calgary. Peter, I don't know if you wanted to have any final words, but that's the end of the slides.
Oh, that's it. And we are trying to push this for, I'm part of an expert panel that is recommending indicators for measurement of quality and long-term care. And we're trying to push this indicator to be measured across all long-term care homes. I think we can going to try to make it happen.
Peter and Christina, thank you very much. No, that was wonderful. And I actually invite anybody, if they can stay for an extra few minutes after 9, please do. I think there will be lots of conversation here. So thank you very much for a great presentation.
Thank you, Douglas. So Christina and Peter, this is excellent. Thank you so much. It clearly reflects some of the stuff I've seen here locally. Some thoughts, and I'm not sure if it's just the timing of the presentation where you don't have enough time, but I wonder if the size of the home, regardless of where it was, or the number of physicians in the home, regardless of where they're located, had any impact on the prescribing habits. And so that was one of the things. The other stuff, which is a lot more difficult to measure, but I wonder if there's a way to look at how deep the goals of care discussions were held, because it would seem to me that if people are already doing good goals of care discussions, then there would be probably a lot more appreciation of the dying process, particularly in frailty, where it's so difficult to predict. The timeline is very different. And that was another comment as well, is I think that overwhelmingly the system underestimates the level of frailty of people coming into long-term care. And as a result, yes, the mean time for survival is 18 months, but over half die within a year of admission. So it's a very, very high turnover for people who have just been told, welcome to long-term care. But no one has told them that, in order to be admitted to long-term care, you got a prognosis of under 2 years. The other aspect, which is also more difficult, is I wonder about if there's a way to measure the quality of the on-call coverage. Because what I do note is that sometimes changes can occur from Friday night till Sunday very quickly in frailty. And if you have a poor call coverage, then I could see medications and the dying process just not being recognized. I don't know how that could be measured, but those are some of the thoughts. I'm throwing out all these ideas because, this is half of what I do in my day-to-day. So those are the things. And then lastly, when I was looking at pre-COVID and the number of people who died in hospital following transfer, that's really quite disheartening. When we talk about hallway medicine, here are people being transferred to an overcrowded system to pass away when they could be passing away at home, where typically visiting is much more readily available from families and friends. And in a funny way, it also reflects the hospital system, their inability to understand or appreciate frailty in the dying process in some people. Now, excluding like fractured hips and other sort of high mortality situations. So those are my comments. Thank you so much. It reflects what I see. So it's nice.
Wonderful comments, Ben. And I guess in short, you read our mind. We're going to be looking at all those factors. We can have an offline conversation, but the co-reg 2, we're going to look at number of physicians in the home, how many years of practice they've been practicing long-term care, what proportion of their billings are in long-term care, Did they, have palliative care experience prior to being a long-term care physician? All those factors we're going to be looking at. We're looking at all the other, home characteristics as well, for-profit, not for-profit. I see your comment, Mary Lou. I'm going to get in trouble again with this study, and maybe someone else can do that study. And then we've looked at home size. All of that is there, Ben. But the beauty about variations research is that those are, I would think of them as mediating factors, right, to good or poor outcome. And regardless of what those factors are, there shouldn't be that much variation. A twofold difference, right? And so if it's home size or if it's for-profit, not for-profit, if it's call coverage, we should fix those those things, right? You know what I mean, Ben? Yeah. So goals of care, is hard. On-call coverage, we can talk online, but we have a survey, so we have some idea about 160 homes, what kind of coverage they have off hours from physicians. But those are all things that we're gonna look at going down this path. But our first paper would be like, this is it. This is the landscape. We're not gonna adjust for anything. I'm gonna try to publish it without adjusting for anything, and then we could say, read it for what it is. There's significant variation. Whatever is behind those variations, we should be looking into fixing it, right?
Yeah, or at least addressing it.
Yeah, exactly. Any other questions? And we have, as you can see, we have an ongoing program of research there. Please, contact us if you have interest in joining the team. We're a pretty collaborative team. And Ben, we're gonna take you up on your offer to be involved. We're looking for more people, from both the quant and qual. We would love to get your, just pick your brain, but we're gonna try to interview the top performing, some bottom performing homes, and see what's behind some of the issues with the, with the practices. But in my mind, everyone should be in quintile 5. Seriously, like everyone should be in quintile 5. Yeah.
I thank you all very much, and thank you for spending a few extra minutes of your day with us. And please tune in next month for October's Family Medicine Rounds. And you can see we have presentations from the Centertown Community Health Center. So thank you all very much, and enjoy your Thursday.